Good day and welcome everybody to this webinar. Today I'm going to talk to you about how we can optimize your dental practice for revenue and enjoyment. And I want to begin by thanking the wonderful folks at Action for providing me this opportunity to spend some time with you and for you to take time away from your life and family to do this. So let's get going. So the first thing is I really believe that we're being misled in dentistry, and that concepts from the 1980s, 1990s, and 2000s, where being busy or having a totally full schedule or feeling tired at the end of the day, this busyness has been substituted as a way to measure our productivity or the health of our business. And the truth is, in today's modern world, in the year 2022, 23, business is not busyness. In fact, my argument will be that busyness is the enemy of having a good business. And so in today's time together, I would like to start talking about how we can use 3D imaging to help reduce the busyness in our practice to help us build a better business. It's this busyness, though, that leads to the overwhelm, the stress, the tiredness, this burnout, this stagnation, all of these things in our practice. And it's understandable why this happens, because we're so busy we're so focused in the beginning of our career to get busy, to fill the chairs, to get our business going, that we never really get out of that mindset. And that mindset of busyness hurts our business. I'm Dr. Tarun Agrawal. I'm a private practitioner dentist in Raleigh, North Carolina, at my dental practice called Raleigh Dental Arts. We have 3 dentists there. And my other business is dental education for a company that I own called 3D Dentists. And I've been doing this since 1999, 23 years now. Being a dentist, 18 years of being an educator, and it's really part of my passion. And over the years, what I've learned is that there's a way to make dentistry simple, and it doesn't have to be as complicated as we are led to believe or that we've made it. And this is our framework for making dentistry simple. It's our 4-part framework, and they're not steps, because really these things overlap each other. And what happens is, at many times in our career, we need to learn how to be able to accelerate our practice. We've got to learn how to slow down to speed up. Kind of like a car that's going through a curve or a turn, they actually slow down and then speed up through the curve. And this is so true in dentistry. And for us, slowing down to speed up is having a good case acceptance process in place. And that case acceptance process, the framework and the fundamentals are the same, but the nuances of it change as we change the type of dentistry we're doing. When we have a limited skill set coming out of dental school, and all of that dentistry is covered by insurance, and insurance pays 50 to 80% of it, the case acceptance process is very simple and pretty straightforward. But as we get into more complex dentistry, as we take more education, as we learn greater skills, as we start having our patients choose to do larger dentistry, that case acceptance process changes. Our use of technology changes, our ability to communicate with the patient changes, the need for making dentistry affordable changes. And then over time, we've got to, or we should want to, and that's why you're here listening, is we want to learn how to grow our revenue in our practice. And that's about learning new clinical skills. That's about expanding beyond what we learned in dental school, and also understanding how technology supports that. And I do want to say this. For me, technology has a very singular purpose, and that is any technology we put into our practice should help drive down the cost of dentistry to the patients. Yes, you heard me say that correctly. I want to lower the cost of dentistry to the patients, but I also want to increase profit to the practice. And oftentimes those don't seem to go together. But I promise you, if we learn to use technology properly and efficiently and in a way to increase our clinical skill set, you can actually lower cost to the patients and increase your profitability to your practice. And then over time, as we get busier, as we learn new skill sets, as we've developed these soft skills and case acceptance, we then have to learn how to delegate so much of this to our team members or to another dentist. So we can bring in an associate or a partner or whatever that relationship may be, so that we can free more time for me as the owner or you as the owner to really start building your business. And then along the way, we have to optimize our practice. We have to look, we have to take in mind overhead. We have to look at business automation. We have to start planning for how we're going to exit our practice. And the truth is none of this is linear. This is something that is ongoing and kind of really never ending. And for me, over 23 years of my career, 22 years of that in private practice, I've learned that I revisit this simple framework over and over again, multiple times per year, or certainly every year, as I add clinical skill sets to my practice. And one of the things I always like to do when learning or going to any seminar or webinar or any workshop or educational program is I always like to go into it saying, what problem am I trying to solve? Or what problem are you trying to solve? Because that helps give us clarity on why we're there. And for many of us, the main problem that we're trying to solve is how do we increase revenue in our practice? And more importantly, how do we increase revenue without creating more chaos in our practice? And really, there's only 3 ways to increase revenue in our practice. I'm sure there's actually more than 3 ways, but there's 3 main ways to increase revenue in our practice. One is we can raise fees. Now, the challenge for most of us, me included, is that if we raise fees, it's somewhat of an artificial thing. For example, our practice is a network with several PPO network plans. And so if I raise my fee, I'm just doing more of a write-off. And it's actually an artificial raise of fees. Only, maybe 10% or 15% of my patients will actually feel that fee raise. So, oftentimes for most of us, raising our fees, while it's important to do, we got to, continue to keep up with all of those things, but raising fees doesn't always increase revenue. One option that's out there is we can see more patients. And this is how often most people are selling us different services and technologies and skills in dentistry is, hey, we can cure your composite in, 3 seconds versus 30 seconds. And over the year, that's going to save you a solid 2 hours of time. And, and the truth is, most of us don't want to see more patients. Many of us are busy enough, or our schedule is full enough. And so we don't want to see more patients, because seeing more patients involves getting more team members, involves getting a bigger building, or any number of things. And the real way that we promote at 3D Dentists, and what I've done through my career, is focusing on doing more dentistry. And what do I mean by doing more dentistry? It's really 2 things. One is I want to focus on a concept of fewer well-planned visits. And what I mean by this is I want to take whatever skill set you have or I have in general dentistry, whether that's a dental school skill set, whether that's a slightly more advanced skill set, and I want to give the patients a chance to do as much or all of their dentistry in a single visit. And what that allows us to do is we do the same number of procedures, but instead of working on 3 or 4 or 5 patients, we can now sit down and work on 1 patient. And so we become more productive on a per patient basis. We maintain our productivity in our practice, but we reduce the chaos by seeing less patients. The other aspect of doing more dentistry is choosing or adding the ability to do more productive and profitable procedures. Things like dental implants, things like orthodontics, things like bone grafting, things like sleep apnea devices, different things like that that do pay more than traditional general dentistry. So, my focus and our focus is always to do more dentistry by focusing on fewer well-planned visits and more productive and profitable procedures. So that kind of leads me into the meat of this webinar for you is a case acceptance process and how technology, specifically 3D imaging, fits into this. For me, the case acceptance process, the puzzle to all of this is we got to learn to diagnose, okay, and give our patients a chance to say yes to the best. We got to have good communication skills to give our patients a chance to want to do more of the dentistry that's available and needed by them. We have to find a way to make it affordable for our patients, and we have to build a schedule that prioritizes the type of dentistry we want to do. And that's super important, especially in super busy practices, where we're running 2 or 3 columns and things like that, which I personally have an issue with, but to each their own. Is I don't think you should be running 2 or 3 columns. I think at the end of the day you should be trying to create and have a very smooth practice schedule that allows you. And the truth is getting on roller skates, this 2 or 3 column type of practice, is a symptom of doing lots of little procedures on lots of different patients, and then leads to rushed hygiene exams and patient exams, so that way we don't diagnose as much. We literally start diagnosing one little thing on each patient every time they come in. And that is problematic. And I'd like to talk to you about this concept, the power of 5%. And I really believe this to the bottom of my heart, is that in dentistry, we don't have a case acceptance problem. We have a diagnosis and communication problem. And we know this, and I'll share this a little bit later on the implant section. We know this because there's roughly 120 million people in the United States missing a single tooth. And yet we only place 2 to 3 million implants a year in the United States. And so that means we have less than a 2% case acceptance of people that could use dental implants. So if we focus on a 95% of our patients are going to say no to ideal dentistry, and 5% are going to say yes, but we focus on giving every patient a chance to say yes to the best and fully diagnosing the patients completely, what we'll see is that we will do more dentistry and fewer well-planned visits. We'll be doing more advanced dentistry, more profitable procedures on our patients. So let's kind of go into diagnosis and communication of our case acceptance process here. So the fundamental philosophy is yes to the best. And I look at that from an old saying I learned in elementary school here in North Carolina, which was do unto others as you would have them do unto you. And basically what that means to me is I treatment plan every patient the way I would treatment plan myself if I were the patient, if my mom were the patient, my dad, brother, any close friend or family member or someone that I love and care for. And I would give them all a chance to say yes to the best. And if a tooth needs a crown, it needs a crown. If the tooth is better served with the filling, it needs a filling. If something should be done before it becomes a problem, we'd be proactive versus reactive. We'd focus on doing dentistry all in as few visits as possible. And we'd focus on making dentistry not as scary by reducing anxiety using whether that's, TLC or whether that's using some type of sedation in your practice. So that's a fundamental philosophy I live by. And that doesn't mean that I focus on overdiagnosing, because I don't. But I give our patients a chance to say yes to the best. If they have rotated teeth, I give them a chance to say if they would like to have straight teeth. If they don't want to have straight teeth, no problem. I don't keep asking them. I don't kind of put high pressure on them or anything like that. And so for us in our practice, what we focused on is three tools, three technology tools to help us diagnose and communicate better to our patients. The most important technology I've ever implemented in my practice has been digital photography. I did that, within my first year of practice using extraoral cameras, and we continue to do it to this day. It allows the patients to see, allows us to give proof of what we're seeing, get the patient involved in what they're doing. Now, when my practice really started taking off with more advanced procedures like implants, is when I implemented 3D imaging, which is what I'm going to talk to you about a little bit more detailed this evening. 3D imaging really unlocked the ability to diagnose. And what I loved the most about 3D imaging was that it created a wow factor for the patient. And there was proof. If I told the patient there's an infection on the tooth and I could show them a big hole in their jaw using 3D imaging, it kind of took away that question of trust. Now, the patient doesn't mean the patient's still going to do dentistry, because not everybody wants to or can afford to or values that. And then to really unlock the potential of 3D imaging as it pertains to dental implants, which has become a pretty big focus within my dental practice, is the ability to use digital impressions to take digital impressions, to do prosthetic planning, to make surgical guides, to do all of these things. So these three tools, digital photography, digital imaging, and digital impressions, 3D imaging, have been immensely important in the level of success that we're achieving, and the type of smooth schedule and the enjoyment that we have in our practice. So funny, my son recently turned 16, and he's supposed to help me drive when we go on trips, on our golf trips. And this is typically what it looks like when we go on a golf trip, is somehow I end up driving and he ends up kind of sleeping in the passenger seat there. Even though he's 16, he should be the one driving me around. But, we kind of go with it. It's probably a little dangerous that I'm taking a selfie while I'm driving there. But let's talk about our baseline of digital records that we take of each patient. Now, I want to be clear. This is where we're at today. This is where I would love to see all dentists get to. But we have to learn to crawl, walk, and run. So, that's the approach we take when we teach is, we got to crawl before we can walk, before we can run. So obviously we take 7 intraoral x-rays. We take 4 bite wings, 2 upper PAs and 1 lower PA. And our real purpose, honestly, of taking intraoral x-rays at this point in time is really just to look for decay. And that's because a CBCT, while it can show decay, there's too many false positives through scatter and beam hardening and different things like that. So we take a 3D CBCT or a 3D Panorex of every patient in our practice. So if you're a patient of our practice, we take a 3D CBCT because I firmly believe that I cannot fully diagnose and provide you the best level of care without having all the diagnostic tools available to us. We also take 6 extraoral photographs of every patient. This way I can show you what I see. And then we're at a stage now where we're also taking a digital impression of every patient that walks into our practice. So through this digital baseline records, we've given ourselves the best chance, based on technologies available to us today, to really help diagnose our patients really well. So let's kind of focus in on the CBCT component of that. So as I mentioned, we take a 3D CBCT on all our patients. So let's dive into what we're seeing. And honestly, today, I really want to keep it pretty simple and focus on 2 aspects of CBCT. One is diagnostic. How can we see more that we don't see on 2D x-rays? And then second part is dental implants. The beauty of all of these softwares is that the software should become a digital hub, a hub for 2D x-rays, a hub for 3D x-rays, and a hub for photographs so that you can have this digital patient record kind of all in one spot to easily share and show with your patients. So let's kind of go through diagnosis using CBCT. And so one of the things I love and was just eye-opening to me is the real difference between 2D X-rays and 3D X-rays. And this is a great example. Here's a patient that comes in, they're having percussion sensitivity and pain on that upper right tooth on this bridge, and they're already missing a tooth, therefore they have a bridge. And, you know, the first thing that comes to my mind when I take this 2D X-ray is I really don't see a lot going on. You know, I see a post of some sort in that root. Since there's percussion sensitivity, it leads me to believe that there's a likelihood or a chance that this tooth could be fractured. And that means I might have to take this tooth out. And next thing you know, the patient is now going to be missing 2 teeth. And so, you know, with my philosophy of, you know, what would I do if this were my mouth? And, you know, I would want a 3D X-ray to help fully diagnose or, you know, see better what's going on in the mouth. And so here's our 2D X-ray, and here's the same patient. Here's the 3D X-ray. And what we can see is there's a reason that we're having percussion sensitivity. And that's because this tooth has a periapical radiolucency. And one of the reasons periapical radiolucencies don't show up in 2D X-rays is for them to show up in a 2D X-ray. And think about this: when you place a sensor on the inside of the mouth, the beam of the X-ray has to go through the buccal cortical plate, through the medullary bone, and the lingual cortical plate. And so it's very difficult to see a periapical radiolucency on a 2D X-ray, especially an early one. And for it to really show up nicely or clearly on a 2D X-ray, it's kind of have to go through it has to go through the buccal and or lingual plate to show up. So in this case, we can see that there's a periapical radiolucency. We can also see that it has a communication into the sinus, and you can see that through kind of what we're seeing in the sinus there. And then if we slice and dice this a little bit more, what we can see is that there's a missed mesiobuccal 2 canal. And there's a good chance that this is the cause of the percussion sensitivity. So, you know, our option is with 2D X-rays, we can refer the patient out because we don't know what we're seeing. We can, you know, make a guess that the tooth is fractured, the tooth needs to come out, or we can make a very logical diagnosis that MB2 is missing because we have a 3D X-ray, and give our patient the choice to consider retreatment in this situation. And that's what I would do if this were my mouth. I would absolutely consider retreatment in this situation to at least give it a chance. And again, some patients will, some patients won't. That's not my decision to judge, but it is in my belief, my obligation to give the patients the choice of what to do there. Here's another one, and I apologize for the graininess. These were screenshots that I took with my phone of my patient monitor. And here we can see a patient that comes in, there's pain on the upper left-hand side. You know, we can clearly start to see that there's something going on. There's some type of something going on in the apex of this tooth number 14. And so we diagnose the tooth needing a root canal. You know, but because we take a 3D X-ray on a 3D CBCT on our patients, what we're able to see in this case, this is more of what this CBCT looks like. And for me, this gives me a little bit of concern as to how successful endo may or may not be. And so for me, first, this gives me caution that I probably don't want to do this root canal because, you know, it's a pretty advanced destruction that's occurred around the tooth. So I would refer this out. Or 2, you know, give the patient a choice that, you know, maybe doing the root canal may not be the best choice for them or the right choice for them. Or the logical choice for them, that maybe taking the tooth out and doing tooth replacement therapy is a better choice for them. So to me, the ability to communicate very clearly, you know, using the 2D X-ray you see on your left there versus the 3D X-ray you see on your right there, to me, it becomes a very easy choice in terms of what we're going to show our patient there, and what's going to be able to communicate the urgency of making the choice and really kind of the destruction that's already occurred in this site there. So let's take a look at some periapical lesions and using the software. So with the Acteon imaging software, when you take a very nice, and these again showing you real case real case CBCTs, you can start to see these periapical lesions here. More than likely, this would not show up on very clearly, at least on a 2D X-ray, because the buccal plate is intact, the lingual plate is intact, but we can see that there's clearly some type of reinfection or non-healed area around this previously treated, endodontically treated tooth. And so to me, when something like this comes in, we start talking to the patient about the situation. We start showing the patient what we're seeing on both 2 and 3. And then we start talking about, here are our choices. Obviously our choice to do nothing and let this get worse. Choice number 2 is, we could refer you to consider retreatment, although I don't, in this particular case, I don't think that's a great idea. Or we can start considering taking the teeth out and replacing the teeth with nothing, or a removable device or dental implants based on the patient's desires and budget. And to me, this level of communication, the ability to see this, and what you will learn or hopefully see as you move into 3D imaging in your practice is you'll see that suddenly this becomes a team-driven conversation and not a dentist-driven conversation, which kind of allows your team to gain new skills, takes a lot of pressure off of you, and your job is to do a final diagnosis and confirmation of what's going on there. So hopefully you can see that. Let's take a look at a cracked root. So again, we can go through the X-ray, we can slice and dice it, we can move it in different increments, and we can make one screen bigger, and we can see right there, kind of where the crosshairs, we can see that's where the root is cracked. And there's no amount of endo or anything that's going to kind of fix that for the patient. So at this point, our choices are, we unfortunately got to take the tooth out. But the great news is we have a way to replace that tooth, and that's using dental implants. So it kind of leads into good diagnosis, communication of everything. And, for those of us that are doing third molar surgery, to me, a Panorex is a nice tool for third molars, but, I like to see the full scope of what's going on here. And again, you can see how nice and clear these images are. And we can see the proximity to the nerve. If this is a case that, as a general dentist, do you want to take on and tackle, or is this a case you want to refer? All of these different things. And so to me, this is kind of, the standard of caring of doing this type of dentistry. I said standard of caring, not standard of care. I want to be clear about that. I wish and hope it becomes standard of care. But right now, we'll call it best practices for third molar surgery or any type of diagnostics. The second part of 3D imaging that has really been amazingly important to my personal career and to my dental practice has been the use of CBCT for implant planning and communication. And to me, there's no real faster way to grow your practice than to implement implant placement and to increase your skill level in that. And here's why. There's 120 million people in the United States missing at least one tooth. 36 million people, I like this image, 36 million people have no teeth. Again, that's 10% of the population have no teeth whatsoever. And 120 million, which is about a third of the population, are missing at least one tooth. And yet we're only placing about 3 million implants annually. And that means that there is a tremendous gap that we as a profession are not filling. And honestly, it boils down to time, fear, and money, and diagnosis and communication. And so for me, 3D imaging allows me to show the patient real time in the hygiene consult room what an implant is, how it looks like, the complexity or simplicity of their, no case is simple. I totally understand that. But the complexity or simplicity of their case allows me to diagnose, is this a green light case, yellow light case, red light case? Is this a case that I want to do? Is this a case I want to refer to my specialist? Is this a case that is reasonable to do? So we can do all of these things by having this type of technology and the software that allows us to plan it. And then one of the nice things about the Action software in particular is it gives us the ability to self-design the surgical guide. We can design our surgical guide in the software, so that way we can choose to print that surgical guide. We can choose to send it to the lab to be printed. You can choose to mill it. The many different ways to produce surgical guides today's world. But this ability to diagnose, to plan and diagnose, and provide and build a surgical guide is amazingly important in unlocking the implant potential in your practice. So to me, this has been, honestly, in today's, at this stage of my career, probably 60 to 70% of all the dentistry I do in my practice is implant related, whether that's setting up sites for implants, whether that's placing implants, whether that's restoring implants. The other dentists in the practice focus on the day-to-day restorative dentistry and so forth. But that skill set wasn't a skill set that I was born with. It's a skill set that I learned, and then I leveraged technology to kind of unlock that potential in the practice. And that hopefully that kind of gives you an idea of the value of CBCT. Many of us look at CBCT mainly as, hey, it's a surgeon's type of tool for those that are placing implants. But if you notice, I spent more time on the diagnostics than I did on the implants. And that's because that, to me, is the main area where CBCT can be immensely valuable and really start to have X-ray vision, see what you can't see with traditional 2D X-rays. And so that leads into, now that we're diagnosing more, we're diagnosing bigger cases, now we got to find a way to make it affordable and build our schedule so we have space to do this. And price versus affordability. My concern isn't that dentistry is too expensive for patients. I think dentistry has done a poor job of making it affordable. And affordability has very little to do with price. Affordability has everything to do with monthly payments. And here's what we know is that when you can keep the monthly payment at an affordable level, people buy more and people pay more. And my best example of this, especially being in North Carolina, is trucks. Trucks today can be $50,000, $60,000, $70,000. And more people are buying trucks and large SUVs, cars that are more expensive. And part of that is because their monthly payments really haven't gone up. And even though the trucks are more expensive, what do I mean that the monthly payments haven't gone up? That's because, when I turned 16, the average car loan was 4 to 5 years. And today the average car loan is seven years, especially for some of these fancier trucks and things like that. And the reason that they've gone to longer terms is so that they can keep the monthly payment at an affordable level for the average consumer. So people buy more and they pay more. So hopefully that helps you understand the importance of breaking treatment down into monthly payments. And to make it easier for our payments, one thing that we implemented and we teach in our programs is what we call a financial menu. Every patient in our practice gets a financial menu. This is automated. It's a Excel spreadsheet that our team members fill out very quickly. They put the dollar amount in there, and it very quickly calculates all the different ways that a patient can pay for treatment. So they can choose the option that makes the most sense for them. I don't want to spend the time explaining all 5 or 6 options to them. I want to give it to them in writing so that they can clearly see what their choices and options are, and they can make the choice of what fits within their budget. So that way that's there. So, kind of give you an idea of how our financial menu works. And the last part here is priority scheduling. When you're in a general dentistry world, in a bread and butter general dentistry world, block scheduling is a dollar-driven production schedule. That's Roxanne Water, very traditional concept that's been around for 20, 30 years now. But as you move into more advanced dentistry, as you start leveraging technology, you start moving to a time-driven process where you're really focused on fewer well-planned visits, and your goal is to have 2, 3, 4-hour visits where you see one patient. And then when you get to another level where you start become known as an expert, or you want to start focusing your practice more on a specific procedure or specific service, you start building your schedule around specific procedures and reserving time for those specific procedures. So that's kind of how we built and how we train and educate our dentists and our various programs on how to really focus on their schedule. So I want to thank you guys for coming on today. I hope through all of this, you can understand how we're focused on making dentistry simple. If you don't mind, I'd like to take a quick moment to talk to you about once you decide that you want to get into the digital world. We have an amazing retreat here in Raleigh, North Carolina. It's a 10-acre compound with 2 buildings on it where we do all of our education here at 3D Dentist. We have our lodge. It's where those that choose to stay on site can stay on site in our 12-bed lodge, where we really get to connect with each other and get to spend time with each other and be like-minded individuals. And we have an amazing education center where we have the ability to really focus on education and whether that's software-based training with computers, whether that's hands-on training for our implants, or even our live patient implant programs where we provide patients for you, or even just our lecture programs or our live streaming programs. And then we have our amazing mastermind coaching program for those of you that want to get out of the chaos and the roller skates in your practice, and you want to take back control of your practice and really build a practice by optimizing that, really want to optimize your practice for revenue and enjoyment. And then we have our business boot camp for those of you that want to train your team on how to do all of this stuff. So I do want to thank you guys for your time. And I think now would be a great time to focus on answering any questions that you may have. Well, it looks like that we don't have any questions at this point in time. If there are any questions, you're welcome to ask for it. If not, I look forward. I'm readily available on social media and all of that. And if you need anything, please let me know how I can help. And I'm happy to do that for you. Thank you, everybody, for your time. And you can reach out to me on social media if you have other questions, or visit our website at 3d-dentists.com if you want to learn more about what we do. Oh, here we go. We have a question. Is your retreat for dental assistants or just the dentist? Our training and our education is very team focused. The retreat itself is typically limited to dentists to attend, but our programs and education is for dentists, dental assistants, hygienists, all dental professionals really within the practice. Now we got another question here. The questions are coming now. I'm happy to answer them. Do the insurance company pay for the CBCT? And the answer is some do. So some dental insurances, sorry, let me click this. Some dental insurances do pay for CBCT. Some medical insurance even pay for CBCT. The approach we've taken in our practice, at this point now, 15 years of having CBCT in our practice, is that we create a reconstructed Panorex, and we bill dental insurance for a Panorex only, and then that's what we charge our patient for. Our CBCT fee is the same as a Panorex, and we do this to keep it simple, to avoid having conversations with patients about this, and so forth and so on. We have another question here. What do you use for interpreting the CBCT? This is a double-edged sword question. Number one, as a general dentist, you're not a dental radiologist, so you're not able to truly professionally read a CBCT. When I do believe it's our best practice and obligation to review every CBCT that you take. every CBCT, I can't say this with fact, I can tell you what I believe, is that every CBCT that you buy should have some type of viewing software with it that you can use in every operatory. And they should provide some level of training, whether that's online or whether that's in person, where that trains you on how to recognize anomalies in CBCT. And then when in doubt, or if you have something in question, that's when I believe that you should refer your CBCT out for a professional reading by a maxillofacial radiologist to CYA and to have a professional reading done. Here's another question. What kind of courses do you provide? We have business courses through our business mastermind coaching program, through our business boot camp on case acceptance for the dentists and the team. And then we have clinical training. Our core courses are live patient implant training programs where we provide the patients for you here in North Carolina. You don't have to travel overseas. And you can learn how to do implant dentistry and work on patients provided for you, whether you're new to implant dentistry doing onesie, twosie implants, or you're a seasoned implant dentist that wants to learn how to do sinus lifts, advanced bone grafting, full arch implants, whether that's removable or fixed. We have live patient trainings for that. We have digital dentistry training programs and 3D printing. We have sleep apnea training and sedation training and orthodontic training. So we have lots of things that help focus on helping you optimize your practice for revenue and enjoyment. So outside of that, we have, so how long do the courses last? Depending on the course, they can be anywhere from 6 days down to 2 days each, depending on the different programs that we do. And you can find more information is 3d-dentists.com. That's our company and our website, and we'd love to see many of you there. So it looks like my time is pretty much up. It doesn't look like there's any more questions. Thank you, everybody, for participating. And anything else, have a wonderful day.